procedure surgeons, colleagues and dear students. A very good evening to all of you. I bring you greetings from my unit from GMC Srinagar. So I am thankful for the organization for allowing me to talk on extraperitoneal repairs of ventral hernias. So as all of you know that operative management of these ventral hernias is still debated because there are so many procedures available and you have to choose on an individual basis which patient to operate by which procedure. So there is no gold standard surgery for these ventral hernias. So laparoscopic surgeries have started for ventral hernias way back in 1993 and was Blank and who started with IPOM those days. And now, right now we are confused. Why? Because we are on crossroads. There are so many techniques which are available nowadays for dealing with these hernias. So what are those techniques available? So minimal access surgery offers you all these techniques. Right from SCOLA, BTAP, BTAP-RS, anterior component, posterior component separation, robotics, IPOM, and so many techniques. So we are confused. So now there are so many names for given to these procedures. So what's there in the name? So broadly speaking, if you classify these laparoscopic surgeries for ventral hernias, we divide grossly them into intraperitoneal and extraperitoneal repairs. So intraperitoneal repairs you already know, IPOM, IPOM plus, and then LIRA is the latest addition for all these. And then for extraperitoneal repairs, you have ETAP-RS, then you have TAP, you have TAPP, you have E-MILOS, you have TAPE, and now robotic surgeries in all these. So now, why are we shifting from intraperitoneal repairs to extraperitoneal repairs? As my friend Dr. Tanvir was discussing about intraperitoneal repairs. No doubt they are very good in safe hands, but there are certain limitations. So what are those limitations for intraperitoneal repairs? So these are first induced visceral complications. As you saw in the previous slides, in the previous lectures, that you have so many complications because of these meshes. You have a lot of adhesions. You can have fistulization of these meshes into the gut, or you can have chronic pain because you are using so many tactiles, so many fixation devices. You have to use coated meshes. These are very, very, very costly as compared to the normal chlorine meshes which we use in extraperitoneal repairs. And now, the most important thing, what about the large hernias? So small hernias, you can deal with IPOM, you can suture them in a tension-free manner, but what about the large hernias? So if you try to suture them, you try to fix them by intraperitoneal methods, you will end up in a lot of tension. The suturing will be under tension and you will have early recurrence. So it's a big question mark for large hernias. Then, what about rectus diastasis? So most of these patients we have seen who have ventral hernias, they have associated rectus diastasis. So when you are going to do IPOM, so there is no way to deal with the rectus diastasis. So when you do extraperitoneal repairs, you have that added advantage. You can re-approximate the edges of the rectus muscle and then you can implement the rectus diastasis. Now why are we talking about extraperitoneal repairs? So as I told you, the answer is there. When you are dissecting in a plane which is in front of the peritoneum or the PR's posterior rectus sheath, it's a well vascularized area because on one side there is rectus muscle and on the other side there is rectus sheath. So this is a well vascularized area, and when you put some foreign body like mesh there, it gets better integrated there, which is not the case with the IPOM. Because IPOM is the surface is a cell-coated area. It's the peritoneum exposed there, the peritoneum, and we have seen in some cases that this mesh gets off easily from the peritoneum. So it's better integrated when you put this mesh in the rectus plane. Then causing effectiveness. As I told these coated meshes, they are very, very costly. And in these procedures, extraperitoneal procedures, you can use simple, normal chlorine meshes, which are very less costly as compared to other meshes. Then you prevent the complications. Complication can be technical related or you can have mesh related complications which can be minimized by using this extraperitoneal approach. Now, since there is no gold standard, but this is the extraperitoneal repair, totally enhanced extraperitoneal repair, which is being talked of as of now in recent years. This has been found to be the standard of care in most of the centers. Why? Because you land up in that plane, which is the ideal plane for placement of the mesh. So this started from the inguinal hernias in early days, who started ETAP in the inguinal hernias first, but then offers by the Dr. Igor Blansky for ventral hernias as well. And the problems with this repair is that it has got steep learning curve, it's more difficult to learn. So, but the people who learn it, it has shown better results in their hands. And now, what are the indications? Which are the patients where you do these type of surgeries? So, most of the hernias, ventral hernias, which are uncomplicated, which are not big, where there is no loss of domain or limited loss of domain, you can offer this kind of surgery to those patients. So, primary hernias can be tackled, incisional hernias can be tackled by this method, and then complex hernias as well. Why complex? Because sometimes you have seen when you operate on a hernia patient has got single defect on CT or clinically, then you find there are multiple defects inside, okay, on table. So those are complex hernias. Or sometimes you have bigger hernias with borderline loss of domain, then this is the procedure of choice. Then sometimes you don't do these repairs, you don't do extraperitoneal repairs. And what are those patients? Who are those patients where you avoid doing these repairs? So there are absolute and related contraindications for these procedures as well. And suppose you have already done a mesh repair in some patient and he has presented to be recurrent. So he has mesh infection, active mesh infection. So you try to avoid this type of surgery because you don't want to get into the planes which are virgin. Then if there is any fistula, enteroperitoneal fistula, or there is a fistula between the any viscera and outside, so you want to avoid these type of surgeries. Then you can have related contraindications to these procedures. So what are the related one? So if you have loss of domain, you need to optimize those patients. First, you need to give either Botox or you need to do PPP, progressive pneumoperitoneum, so that you don't land up in intra-abdominal hypertension in the post-operative period. Okay. So after that, sometimes if you have large skin available, the hernia is quite big, you want to tackle it in two ways. That's called as hybrid repair. So you want to excise, you want to chop off the excess skin as well. So you will end up in doing abdominoplasty that time as well. How do we assess these patients when a patient of hernia, abdominal hernia comes to you? So how do we assess them? So this is the checklist. As for other surgeries, what you do is you take a proper history and you do a detailed physical examination of the patient who has landed up with you for hernia surgery. So after examining you properly, what you do, you order for the routine baseline investigation, the biochemical investigation, and then you send him for imaging. Imaging is very important in ventral for hernias. So what is the imaging of choice you do? Is the contrast enhanced CT of the abdomen along with oral contrast as and when needed. So what are the things you want to see on that CT? Apart from the routine things which your radiologist friend tells you about the CT of an abdomen of a hernia patient, you have to ask for something special in that. So what are those special points? You need to ask for the hernia defect size, the number of the defects. Then you need to know about the muscle quality. What is the quality of muscles? After that, you need to see if there is any prior wound or if there is any collection or some sort of wound complication that has to be seen on CT. If the previous surgeon has used any mesh or something like that, you can see that clearly on the CT. If there are some adhesions, bowel adhesions, or whether there is some fat plate maintained between the hernia sac and the bowel, so all those things can be seen on a CT scan. Then this is the position when you just plan this patient for surgery. So how do you put him on table?
Dr. Hamid, try to be brief, kindly. Try to be brief.
So this is how you place the patient on the table. Patient is lying spine on the bed and his hips are extended. His both arms should be tucked by the side, and then this is the overall layout. So surgeon, assistant, camera person and the scrub nurse, they have to be on the same side of the surgeon, and the monitor is completely opposite to that of the surgeon. Then this is the standard port position for 4-port E-cap RS. The first port is the A, it's in the left hypochondrium. It's the dynamic port where from you start the surgery, you just insufflate, you can push any sort of trocar here either manually or you can use a busy port which is available. And then after that you create B and C are the working ports on the left reproductive space. Then sometimes you can add one more port in the right hypochondrium, which is an additional port, and some surgeons who are too experienced, they can omit this port. So this is a short video. You can see busy port is being used to enter into the left rectal space in the left space, you have to stick to that area. And after that, when you have put your first vertical code, you can use any energy device to make a proper plane. Made a left reflector space properly, then what you do is you just divide the left PRS close to the midline, close to linea alba, sticking around 0.5 centimeters away from the insertion into the linea alba. And that yellow tissue which you are seeing is nothing but the fat of the falciform ligament. So this is called as the crossover. So you crossover the other side. So after you divide this fat, you can see the posterior rectus sheath on the other side, and after confirming that this is the rectus sheath and not the linea alba itself, you enter into the right rectus space and try to make a space in the right rectus region. So when you have divided the right rectus space as well, then you concentrate your attention on the hernia itself. When you open up your hernia sac, see for contents, what are the contents, try to reduce the contents back to the peritoneal cavity after proper hemostasis. So the sac is being divided, the contents are being reduced. You can see momentum is as a content there. We check for the hemostasis. Reduce the momentum back to the peritoneal cavity and continue with your dissection beyond the lower limit of the hernia itself. So now when you have divided enough space, then what you do is you close the posterior defect in the peritoneal PRS complex by absorbable on any braided suture, barb suture, sorry. So when you have closed the peritoneal PRS complex, you go to the anterior rectus sheath and then close the hernia defect. And if there is any rectus diastasis, you ligate that as well.
लेग स्पिन दे यार, लेग स्पिन है ना सर, तो लेग स्पिन ही कर रहे ना, मेरा आपसे कुछ होता है। मैं हमेशा ऐसे करता हूँ सर।
After that, you measure the space and deploy the appropriate size mesh, simple poly mesh in the rectus space and you don't need any brain. So, what are the advantages now of this beta RS are that there is good vest integration because the area is well vascularized and there are chances of less rectal spike because you are closing the defective foliage. You are closing the PRS complex individually separately and the anterior rectus sheath separately. Then there are three issues of pain as well because you don't use any fixation devices, you don't suture it much. Pain obviously will be less. And then since the repair is extraperitoneal, all the regions will be very less, they will be minimized and at the end it will be quite economic for the patient. Sometimes what happens, you are not able to close the defect in the PRS. Since the hernia is very large, what you do is you add tar to it. So what is tar? Tar is nothing simply.
Summarize please.
Last question. So it's just simply going beyond the rectus space, either on one side or on both sides, so that you close the PRS properly without calcium and then deploy a larger mesh. In conclusion, the search for perfect repair remains elusive. Evidence is accumulating still, and we are still at crossroads, which I mentioned in the first slide. And then rectus mesh placement is preferred, is to be preferred because of the advantages which I have described, and ATAP seems to be promising as of now. So hernia repair can't be idealized.
मेरा
So it
second
needs to
bit
be
है
individualized for every patient. Thank you very much.